welcome to the National Dialogues on Behavioral Health Conference, Session 5, Physical Behavioral Health Integrations, FQHCs, CCBHCs. My name is Jessica Flick, and I'd like to introduce your host, Vijay Ganju, the President of the National Dialogues on Behavioral Health. Vijay, over to you.
Thanks, Jessica. And welcome back, everyone, to the 5th session of the National Dialogues Behavioral Health Conference for 2021. My name, as Jessica said, is Vijay Ganju, and this year I am the president of National Dialogues. And it's, again, a great pleasure to welcome you all to the 5th session. I think we have a very exciting session planned. I'm going to sort of do a quick introduction about the organization, and then I'm going to turn it over to Stephen Philippi, who is the chair of the Department of Behavioral and Community Health Sciences at the Louisiana State University School of Public Health. And he will be introducing the speakers and then sort of managing the questions and answers and all that all of you have later on. So with that, Jessica, if you can turn on my screen. I'm not going to really sort of dwell on a lot of my presentations. I think some of this is a repetition from last time, so I will try to cut through this in quick order. So next slide, please, Jessica. As I've mentioned before, the National Dialogues on Behavioral Health is the oldest behavioral health conference in the United States. This is our 62nd annual conference. Usually, as I've mentioned before, it's in New Orleans. And in the picture that you see there, you actually see people outside the hotel where the conference is, seeing some floats because we were having the conference at a time that overlapped with what was going on for Halloween a few years ago. Anyway, the topics are sort of cutting edge. And can I go back to the slide I was on, please? Yeah, thanks. And right now, I think part of what I want to emphasize is that we do have cutting edge topics that vary from year to year. It's a 100% voluntary organization. And as people describe their experience at our conference, they do describe it as a sort of a jewel and a gem of a behavioral health conference because it allows a lot of networking and interaction. And so people seem to have fun as well as learn quite a bit. Next slide, please. And, you know, I'm not going to go over this, but this gives you some idea of the range of topics that we've had that range from sort of preventing criminalization of persons with mental illness to, you know, how you promote resilience, how you create value and measure value. And last year, our focus was really on implementing behavioral health crisis response systems. You know, we had sort of an earlier session in this conference on the implementation of the 988 line. And so those are the kinds of things that we try to cover. Next slide, please. And as I mentioned before, we usually have a full day pre-conference at these conferences. And these are some of the topics that we've covered, including, you know, how to incorporate mindfulness, exercise, and alternative medicine, artificial intelligence, what's been going on in school mental health prevention and early intervention. And and those are just focused topics where we spend the whole day on this particular area. During this virtual season, we haven't really had any of those pre-conferences. Next slide, please. And just, you know, I know some of you have seen this before, but we have these are all our executive committee members, and they're from all over the country and represent a whole range of organizations. Next slide, please. And, you know, we have several organizational partners, and they include the National Association of County Behavioral Health and Developmental Disability Directors, WICHE, the Western Interstate Commission for Higher Education, and the National Association of Mental Health, of State Mental Health Program Directors. Next slide, please. And, you know, we have sponsors that essentially support some of the activities we have associated and some of the costs that we incur with each of our conferences. And this year, the 3 organizations that have been very, and some of them have been long-term supporters, have been Access Health Louisiana, Benchmark Human Services, and Genoa Healthcare. Next slide, please. And so just a few housekeeping instructions. As I think you know, you all know, please use the Q&A function to ask questions or make comments. It's very helpful if we know who is asking the question or making the comment. So please include your name. And if you can include your state, that would be helpful. CEUs are available, and I'll talk a little bit more about how you get those. And for those of you who would like captioning, that too is available. All you need to do is at the bottom of your screen, just turn on subtitles. And then please, please, please complete the online evaluation, because that's what sort of tells us how we've done, but also gives us suggestions for next year's topics, and as well as any feedback that you have. And the way you'll do that is there will be a screen that comes on after this entire conference is over. And if you just click on it, it'll take you straight to that survey that needs to be completed. And it'll take you about 3 to 4 minutes to sort of complete that evaluation. Next slide, please. And so for your CEUs, and I think most of you know the routine, if you haven't registered for CEUs, please send an email, and I'll repeat this, melnor64@yahoo.com to Melanie Norwood. And, you know, at the end of this session, I will be providing a unique code word, which you will need to include on the CEU evaluation form that you'll receive from Melanie. This CEU evaluation is different than the session evaluation. So I just want you to know that there's a distinction between those 2 evaluations. The next slide, please. And for those of you that are interested, the evaluation for the session evaluation is at this URL. As I said before, it will be coming on your screen at the end of the session, which you can click on there. But if you want to note it while it's up right now, then that too is a way that you can access the SurveyMonkey evaluation. Again, I want to say a couple of things before I turn it over to Stephen. One of them is that one of the speakers that we had on the original brochure wasn't able to make it, Barbara DiPietro, and there was some miscommunication, misunderstanding about her participation. And Jerome Corley, who is one of the speakers now that Stephen will be introducing, stepped in at sort of the very last moment in a way. So just want to thank him. I also want to thank his supervisor, Lathran Woodard, who is the executive director of the South Carolina Primary Care Health Association. And so again, I want to give special thanks to Jerome for joining us today. With that, Stephen, it's all yours. Thank you. And thank you all. I want to thank all the speakers for joining us. So with that, Stephen, I'm turning it over to you. Thanks.
Excellent. Thank you so much, Vijay. And thanks for all of y'all for being here, and very excited about this presentation on this whole collaboration between physical health and behavioral health and integration. Interestingly enough, one of my very close friends and colleagues is over at the Medicare Medicaid Innovation Team in DC. And when I asked her what was the big up and coming focus, and this was a couple of years ago, she said it's all about FQHCs and CCBHCs. So this integrative care is where it's at, and that's where all the focus is. So very excited to have this panel. You all are in for a treat. As VJ said, I'm the moderator for the panel, Stephen Philippi. I'm at LSU School of Public Health, and I run the Behavioral and Community Health Department there, and also direct something called the Center for Evidence to Practice. So I'm looking forward to hearing the presentations, asking some questions, but as you all know, this is participatory, so we want questions from you. There's a reason we call it the National Dialogues. We do want to hear your questions. What do you want to know? The panel, in terms of the order, we're going to start with Dr. Gail Daumit, and then go to Dr. Joe Parks, and then Jerome Corley in that order. I'll do a very brief intro. Each will present, and then we'll pause for just a couple of questions in between presentations. We'll do the next presentation, and then at the end, we'll do a bigger Q&A. So feel free to, at any point, insert a question into the Q&A panel. And just to start, since you all know, this is interactive, we have a poll question for you all. So we want to know who's out there. So Jessica just put up the poll question. It's a simple yes or no. How many of you are participants in a formal collaboration between primary care and behavioral health? And it's just a simple yes or no. We're just interested in who's here, who's in the audience at this point. We'll give you a minute. And Jessica, when they're ready, if you can display the results, that would be great.
Absolutely. It looks like right now we have 60% yes, 40% no.
Wow. So
25% participated.
Fantastic. So a whole lot of people, the slight majority that are already participating, but a whole lot of people where this may be some new information. So I would anticipate for those particularly that aren't involved yet, thank you, I can see the poll now, appreciate it. And then for the people that aren't in those collaborations right now, probably some good takeaway information as well. So thank you for that. All right, so we're going to jump right in. And first up, do a quick background, and I say quick because this could go on for quite a while. We have Dr. Gail Daumit. She's a professor of medicine at Johns Hopkins University School of Medicine. She holds a joint appointment in psychiatry and behavioral sciences. She also holds appointments in epidemiology and health policy and management at the Johns Hopkins Bloomberg School of Public Health. Her areas of clinical expertise include clinical trials, epidemiology, and health services research. She earned her MD from Emory, and she completed her residency at Massachusetts General and performed a fellowship in internal medicine at Johns Hopkins, earning her MHS in epidemiology from the Johns Hopkins Bloomberg School as well. Dr. Daumit's research is devoted to improving overall health and decreasing premature mortality for people with serious mental illness, such as schizophrenia and bipolar disorder. Her work has been recognized with several honors. In 2013, she received a Society of General Internal Medicine's Best Published Research Paper of the Year award for the randomized trial of achieving healthy lifestyles in psychiatric rehabilitation. So very excited to hear from Dr. Daumit, and without further ado, I am going to turn this over to you.
Great. Hi. Thank you for that very nice introduction. I'm Gail Daumit. I'm very honored and excited to be here with all of you all and to speak a little bit about what I'm working on and how it relates to the critically important issue of physical and behavioral health integration. And I'm again very honored and excited to be part of this panel. So I'm going to be talking about really the kind of the research background, the evidence base for what we know about improving physical health for people living with serious mental illnesses. So that part of the behavioral and physical health integration. So as I'm sure all of you know, people living with serious mental illness have a very large excess mortality compared to those that don't. This has been shown over decades in many different countries, and with some of the formative work by my mentor who's on this panel, Dr. Parks. This is an example of work that I did over a decade ago in Maryland, where we showed that we also showed that the all-cause mortality rate for people living with serious mental illness was over 3 compared to those without. And if we look at the top causes of death, they're all elevated. And that the most common causes are really heart disease and cancer. And other than HIV, which was particularly elevated, that all of the other top causes of death, such as diabetes, stroke, lung disease, really mirror the overall population. So while suicide and accidental death is very important, it's not contributing, it's not a top cause. That really we're looking at many of the same medical comorbidities as the overall population. So just as a reminder, people with serious mental illness have elevations across a range of medical conditions. So all of the cardiovascular risk factors and risk behaviors are elevated at least 1.5 to 3 times. Overweight and obesity, physical inactivity, particularly tobacco smoking. In addition, diabetes, high blood pressure, and high cholesterol in terms of the cardiovascular risk factors. And then many cancers are elevated, chronic lung disease, liver disease, and HIV. And we know, unfortunately, that across many health systems, not all, but many health systems, that healthcare quality for these conditions, physical healthcare quality, is lower in people living with chronic mental illnesses. The World Health Organization a few years ago called this out, and I was fortunate to be on the guideline development group for this. And they called out this issue of management of physical health conditions across the world in adults with severe mental disorders as being a really important priority that countries and health systems should address. So I started working in this field close to 20 years ago. And I started working, I started doing kind of more observational work and kind of describing these risk factors that were elevated. But as a primary care physician, a general internist with kind of epidemiology training and training from people that had done a lot of the large NIH-funded studies of like how to reduce blood pressure and reduce weight in the overall population, my mentors pointed me towards really not just describing the disparities that people living with mental illness face, but really trying to do something about them. So I really then turned to interventions as non-pharmacologic interventions as a way to really try to help these people living with serious mental illness. So I started working on grant proposals to look at how I would pilot a weight loss intervention in psychiatric rehabilitation in Maryland. And when we think about the needs of this population for, let's say, diet, counseling, and increasing exercise per se, we really need to think about the people and the clients that we serve, and that they may have barriers to going to like Weight Watchers or going to the gym easily, and that although there is a desire to change health behaviors often, that the same exact protocols or leaders, guides for diet counseling and things like that, that like are work in people that are not living with mental illness might need tailoring for people that have schizophrenia, for example. They may have persistent psychiatric symptoms or cognitive impairment, and day-to-day functioning is a little harder. And so when we design interventions for them to lose weight, we need to be cognizant of that. Really, in many ways, this population is a disparities population. Similar to other health disparities populations, they share a lot of the same socioeconomic and environmental risk factors, and it's important to think about how we would tailor interventions for that group. On the positive side, if we really look to mental health services that that people are often engaged in, there is opportunity in those services and organizations to potentially really serve this group and really include wellness and physical health activities in those settings. And so that's what I essentially have spent my career working on. So I did, Stephen did, mention that I had done this trial called the Achieve trial, which was a weight loss study funded by NIMH that was successful. We showed that weight loss with this tailored intervention, but then our stakeholders, our leaders in our mental health programs in Maryland came back and said, okay, but like, now what about smoking and what about high blood pressure? CVD or cardiovascular risk factors are very prevalent in this population, as I said, and many people have more than one. So it's hard to just address one risk factor at a time when someone might smoke and have diabetes and be overweight and have high blood pressure. So I needed to think about interventions for that. And at the same time, really, what we know about integrated care settings is that, and we're going to talk, the other panelists are going to talk more about those, that for people with serious mental illness, there are a lot of programs around that are integrating physical health, but most of them have not shown that they can actually lower your blood pressure or have you quit smoking, because the intensity needed to do those things, as I alluded to, in terms of having a tailored intervention and kind of working one-on-one with the population, the intensity is high, and currently health homes, and I think most other integrated care programs are not set up in that way. And I'm going to talk a little bit more about that in a minute, but just as kind of an overview, one of my trainees wrote this article that was published in 2018, where she reviewed the literature on behavioral health homes, Medicaid behavioral health homes for people with serious mental illness. And she did find in the studies that she reviewed that there was increased utilization in primary care, which is great, increased screening for things like high blood pressure. So that's really great. But again, she couldn't find evidence that most of these programs, or that these programs actually improved blood pressure itself, lowered cholesterol, lowered weight, or had people, quit smoking. And that, there was just a lot of variation, of course, in how services were delivered. And there's kind of the infrastructure there to, I think, actually improve physical health, but that it hadn't been realized yet. So I'm going to talk with you now about 3 projects. The first one is a completed study, which I'm going to talk with you about. And the second 2 are in the field now. And then we can make some conclusions about how these fit into integrated care settings and what we can learn from them. So I remember when I showed the slide that said, well, people have multiple risk factors. So after the Achieve trial finished, we got funding from the National Heart, Lung, and Blood Institute to do a study we called the Ideal trial, which was looking at all cardiovascular risk factors for people with serious mental illness in certain psychiatric rehabilitation programs in Maryland. And so this study was published last year. And essentially, the interesting thing about this study was that the study actually started at the same time in 2013. The behavioral health homes were starting in Maryland. But when we did the study, we weren't actually with a behavioral health home in the programs we worked with, if that makes sense. So we didn't know at the time when we wrote the proposal that the behavioral health homes were going to be implemented like they were. And so an interesting thing about this study, which I'm going to explain to you, is actually the findings of the study, are very, I think, transferable into a behavioral health home model. So this project, essentially, we had 269 people in Maryland in 4 community mental health programs. And we were looking to see if the overall heart disease risk would decrease. And this is using something called the Framingham score, which some of you may have heard of, which primary care physicians use to estimate like the risk that someone's going to have a heart attack or a stroke within 10 years. And we had an intervention that we did, which I'm going to describe. And we actually found that our intervention was successful and decreased heart disease risk significantly. And that had never been shown before in people with serious mental illness in this kind of intervention, or really at all. Okay, so what was our intervention? So what did we do? We were in psychiatric rehabilitation programs, essentially settings where clients with serious mental illness came at least once a week. And we had an intervention that was delivered one-on-one. We had a health coach that was actually hired by the program and trained by us. And then we had a nurse who was trained and was a university research staff. And what we did was that we had counseling sessions. The intervention was for 1.5 years. We had counseling sessions one-on-one with the participants. And we also, the nurse collaborated with primary care physicians and psychiatrists for evidence-based management of cardiovascular risk factors. I'm going to explain that on the next slide. And then we coordinated with mental health program staff and social supports to advocate for and encourage reaching health goals. So because the health coach was for the most part an employee of the mental health program, they were very embedded. They were embedded in that mental health program, and so they were able to bring heart disease risk factors kind of to the forefront during like regular meetings and things like that. So a couple of points I want to talk about with this intervention. One is that, when people have more than one heart disease risk factor, the intervention accounted for that and took into account what the participant wanted to work on. And we were able to work with them either on risk factors like together simultaneously or in a row or sequentially. So depending on what they wanted to work on, and then what the team thought were like kind of the more important things. So for example, like if they were willing to like work on quitting smoking, that's going to cut your heart disease risk the most, right? If they weren't willing on quit smoking, we would work on something else first and kind of then circle back to that. The other thing that we did that was really interesting and I think is very applicable to current integrated care models is that we had a systematic way to work with primary care physicians to share the cardiovascular disease risk factor profile, to provide guidelines to them and advocate for evidence-based monitoring and treatment. It may be that in closely in co-located or closely integrated care settings that this is not as needed. However, the way the behavioral health homes work in Maryland, it's much more decentralized, and you have a large number of primary care physicians that are caring for like a few health home members each. and that qualitatively we did find some kind of, we call it clinical inertia, where there's some kind of maybe unconscious bias or stigma where for people with serious mental illness, primary care providers were less likely to kind of maybe like increase their dose of a blood pressure medicine themselves or put people on a statin for high cholesterol. Whereas when we had the nurse advocating for the patient, it was helpful, it was more helpful, and coordinating around lab draws for blood monitoring and making sure people got their prescriptions, et cetera. So this was done kind of in a population health framework. And again, we did show that we had a significant decrease of almost 13% in the change in the 10-year risk. And then interestingly and importantly, so tobacco smoking was independently also declined. The other risk factors declined each a little bit, but they added up to a decrease in risk, but tobacco smoking declined by itself significantly. So that's great. And I was really excited about this study. It was, in part delivered by real world mental health staff, but the nurse was definitely our employee. And either way, we really need to kind of scale these interventions up and, get them, even more out into the real world. So the next two projects I'm going to describe are trying to do just that. So one of them is part of a NIMH funded Alacrity Center. We have an Alacrity Center at Johns Hopkins. It's the Center for Health and Longevity and Mental Illness. And we have 3 pilot projects. And one of the pilot projects' goal is to really look to see ways to have health home teams work in a quality improvement way to increase the delivery of evidence-based cardiovascular risk care, factor care that they're giving. So what we're doing is we're using something called the CUSP model, the Comprehensive Unit-Based Safety Program model, which is an implementation strategy. It's a quality improvement method that the Johns Hopkins Armstrong Institute developed and has been tested extensively in inpatient settings, like for hand washing or for like central line changes to decrease infection, for getting for urinary catheter removal. And it has not been as much used in the outpatient setting. And so it's a team-based quality improvement model. So we're working with 4 psychiatric rehabilitation programs that have Medicaid health homes in Maryland. And what you do in the CUSP model is you start with something called an evidence-based bundle that we put together. So our bundle for behavioral health homes has both a clinical part, which is like a protocol for how to, like, kind of a simple way to care for heart disease risk factors in a behavioral health home. Like, what do you do when the blood pressure is this? When does someone need a cholesterol medicine? And then it's really tailored to people with serious mental illness. And it's kind of targeting a nurse level practitioner. And then we have something called the care coordination bundle, which takes some of the principles from the IDEAL trial that I was explaining and really puts them in more of a process map for care coordination, care management, population health, so that it's sort of like, how do you manage the heart disease risk in kind of a population like a health home or other integrated care setting. So we've got these toolkits, so to speak, and we deliver them. And these are just some examples of some of the things in our toolkit, like how to communicate, how do they can use a database for monitoring the health of their population for heart disease risk factors. How do they speak with physicians' offices in the most effective way? We have templates for that. And then how they should work, suggestions for how they should work as a team to work together on issues like how to, working on issues with prescriptions and medication compliance and things like that. So that's that project, which is really cool. I'll briefly introduce this other project where we're in partnership with the University of Michigan and behavioral health homes and other integrated care programs in that state with Maryland. Dr. Amy Kilborn, who's the head of the Query program in the Veterans Administration, is my co-lead on this study. that's part of the Decipher program that was funded by the National Heart, Lung, and Blood Institute, which has funded 7 different studies. Ours is the only one that's focusing on serious mental illness for heart disease risk factors. The other studies are focusing on other populations. So what we're doing here is we're really looking to look at different implementation strategies for integrated care programs in both states to support the evidence-based practices really that I described before. I mean, the ideal intervention is one of them. And then another one is called Life Goals that Amy Kilborn developed, which is a little bit more on like the self-management of physical health. And then we're combining these interventions, and essentially it's a 2-phase project. The first phase is a planning phase that we're in now with a lot of community engagement, stakeholder engagement, and that how would this intervention fit into integrated care models so that it could be like actually used and sustained and supported, so that we could actually decrease heart disease risk. The second part of the study is a trial, a special kind of implementation trial, where we're going to test out different strategies to support these evidence-based practices. So I think I'll sort of just kind of skip over a couple slides and finish and say that, health disparities and heart disease risk factors and mortality in persons with serious mental illness are very large. They remain large even despite our efforts, and that we do have evidence-based interventions that work. I described mine, there are also others, and we really need to scale these up in real world integrated care settings. The studies I described are trying to do that, but we need, we really need to just do more. We need to be interacting with more states, more programs, think of more strategies to make it easier so that integrated care programs can really be able to be set up so that not only do they do all the other things that they're supposed to do, but they actually can improve different aspects of physical health. So thanks for everything, and I appreciate it.
Thank you so much, Gail. So I do have just a quick question, because I'm gonna lean in on your research aspects of all this. Are you all seeing, especially in the realm of engagement and that level of bringing this diverse level of care to folks? Are you seeing any dosage response kind of things? Is it how long, how much does it take to really get people involved in this kind of integrated environment? You're on mute.
Sorry, you mean to get clinicians involved? Is that what you mean? Or to get?
Actually, both would be great,
both.
clinicians
Right.
and the consumers.
So I kind of skipped over this a little bit. But I think, right. So I think that, the studies that I have done have all been 18 months in length. I think that these risk factors, particularly smoking, they take a while to work on, and that people need to be ready to accept medication for smoking, counseling for smoking, et cetera. So I think that the key is that these are chronic conditions, and that in the overall, and people who are not living with mental illness, they're not quick fixes. And in this group, it's even less of a quick fix. So I think we're thinking higher intensity, higher dose, longer. And so that is kind of an issue when we talk about, well, like, who's paying for it? How are we scaling it up? So the projects I'm working on now are trying to like make training really short. Like, what is the minimum dose, of training and things that we need to deliver so that providers and clinicians can deliver them. I think on the provider side or the clinician side, I think not so much on these exact studies I mentioned, but on other ones we have in the Alacrity Center. What we have found is that COVID is a stressor to an already stressed system, and that people want to work with us on these risk factors. They think it's important. But the mental health workforce is stressed, and it's like, how do we fit it all in so that it can be done and reimbursed and it's challenging. So I don't know if that's like an answer, but I think that we need like more focus on this and more and less kind of feeling like this is task shifting and more about embracing this as wellness. And it's like a role that would be supported by, you know, throughout an organization and kind of reimbursed or valued.
Excellent. And I like that whole organizational approach. As an implementation scientist, we often forget we've got to bring everybody on board, not just train the clinicians. So thank you for that. And I do see there's a question from Tina Hicks in the answer that I'm guessing we're going to repeat more than once and probably get to again at the end. But I think, Gail, it's an opportunity. You might want to take a stab at this because it goes, that's a good segue from your last comment. Mental health services need to grow with our community. How does the panel feel about whole health management? I don't know if you want to.
Yeah, I'm not totally, I want to make sure I understand the definition about like whole health management. Like, does that mean like people coordinating or does that mean like one person managing it? I mean, I'm all for coordination, communication, accountability, like who's accountable for what. I think things fall through the cracks. We're not reimbursing. I mean, I think Dr. Parks may be telling us something else. So, but just the Medicaid health home models generally don't reimburse, you know, are not reimbursing the primary care side, at least in our state. And so I don't know if that's answering the question, but I think we probably need whole health management if I'm understanding what it is.
And I'm sure we can get back to it and Tina can maybe clarify as we go through the presentations toward the end. I'm going to throw out one more to you because I do think this is relevant as well. And then we'll move on to the next panelist. But what have you put in place to keep patients engaged in an integrative care model? We have difficulties keeping our clients involved and compliant.
Yeah. So I think that some of what we do, I mean, I probably have done less for quote the model and more for kind of like engaging them in physical health. I think that, you know, most people want to be healthy. They might not know how to do it. And really most people want to quit smoking. I think it's like a fallacy to think, you know, that people with schizophrenia, for example, don't want to quit smoking. They most do. So I think some of it is kind of using motivational interviewing practices to get to like what benefits would be to them if they quit. Like they would feel stronger, their family would be less worried, etc. Or like, for example, with weight, how would they feel if they had a different pant size, or they were able to lift more or do more things with their family, or do more things at their job. And so we use motivational interviewing practices. It seems to work well. That's not to say that everyone's engaged, but I guess we've had good luck with that approach.
Fantastic. Excellent. I am a big fan of motivational interviewing. I'm glad to hear it part of it. All right, so we're going to shift gears. We're going to go to Dr. Joe Parks. If you want to turn back on your video, Joe. So just briefly, thank you, Gail. Thank you so much, and don't go too far. We're coming back with questions shortly. We have the pleasure of having Dr. Joe Parks on us. He currently serves as the medical director for the National Council for Mental Wellbeing and is a distinguished research professor of science at Missouri Institute of Mental Health with the University of Missouri in St. Louis. He is the National Behavioral Health Representative at Large for the Joint Commission. He practices outpatient psychiatry at Family Health Center, a federally funded community health center established to expand services to uninsured and underinsured patients in Columbia, Missouri. He previously served as the director of Missouri's HealthNet division, which is Missouri Medicaid, in the Missouri Department of Social Services. He was also medical director for the Missouri Department of Mental Health in Jefferson City and the division director for the Division of Comprehensive Psychiatric Services. So without further ado, Dr. Joe Parks.
Well, thank you, Stephen. I want to say, Gail, wow, what an impressive array of specific programs and what an incremental build on what you can do individually in terms of direct interactions. And for our audience, the point I want you to remember as I speak, I'm going to speak about some broader system and payment issues and a financing and delivery model. But at the end, integration is really about what we individually do with the patients, with the clients, with the consumers, and what we individually do with each other, whether we're behavioral health psychiatry or primary care general medical. It's about individual behaviors. It's not at the end of the day about the structures. I'm going to talk about structures that support it, but Gail showing how her clinical staff was having the individual action is where the real traction is. Let me go ahead and share my screen. Am I coming through okay there?
Perfect, thank you.
Very good. Okay, I'm going to talk about a particular integration model. I'm going to talk about certified community behavioral health clinics, which for me coming out of Missouri was the next incremental build from the health home program. And we'll get back to that health home program question about the extent to which it supports primary care or not. I like that question you asked, Gail, and we'll address that during the Q&A. So what is a CCBHC, a Certified Community Behavioral Health Center? It's an integrated behavioral health model of care that improves accessibility and also quality. It focuses on integration. It also focuses on evidence-based, trauma-informed, and recovery-oriented care. It has a comprehensive array of services, including both mental health treatment, substance use disorder treatment, and primary care screenings. And it is a coordinated, integrated model in that it requires collaborative relationships with a wider range of providers, both healthcare providers and social determinant of health service providers. It really sits on four main pillars. There's a standard federal definition. Now, this is the first time when CCBHCs came out in 2017 that we've had a federal definition of what it is to be a community behavioral health center. The old CMHC definition was taken out of statute in 1980 when its funding was put into the block grant program under SAMHSA. And so when they'd ask us at the National Council, how many CMHCs are there nationally, until CCBHCs came around, we had to say, I don't know. No definition, can't count them. So having a standard definition really helps you manage and raises the bar for service delivery. What is it? What is it not? It rests on evidence-based care, and I'm going to show you a list of 9 broad categories of service required. And then there are many subcategories along the lines of the kind of interventions Gail was showing. It requires quality reporting, over 20 performance measures. This is data-driven care, and CCBHCs are held accountable by data. And it is all supported by a prospective payment system where the rates are actually set to cover the costs of care, including the costs that are not usually directly attributed in a fee-for-service payment. Can you imagine that? Having rates that are actually set to cover the costs of doing the service. So it has grown rapidly. Here's a map of CCBHC nationally. It is in 430 different clinic sites across 42 states. There's a couple different versions. There are 10 states now that have statewide demonstration projects getting the prospective payment. There are another over approximately 36 states, 37 states that are getting expansion grants. Some states have both the demonstration and the expansion grants. And then there are states like Texas and Kansas that are implementing their own under alternative Medicaid authorities. It's grown rapidly. It was launched in 2017 with the 8 demonstration states. And as I said, we're up to over 40 states, 430 clinics on a whole range of different payment methodologies. The major payment methodologies are the Medicaid demonstration. There's also the federal expansion grants that are federal grants to individual agencies. And then there are the individual states that are doing a state plan amendment or a waiver. And currently the demonstration is funded through 2023. The expansion grants are still rolling out. There's going to be another slug of expansion grants coming out in the next 6 months or so. Still expanding, and solid funding up to 2023 at this point. So what goes into it? There's a couple of different categories of requirements. SAMHSA actually has over 114 certification requirements to be a certified community behavioral health center, and regarding organizational authority, staffing, access to care, scope of services, a lot of coordination of care requirements, which of course goes directly to integration, and then the quality reporting. You have the prospective payment or the grant that fills in the gaps in the usual fee-for-service payments until that agency or state can implement prospective payments. The grants are currently $2 million a year for 2 years for the expansion grantees. So to drill down a little on the organizational authority requirements, CCBHCs have to be nonprofits or part of local government, behavioral health authority, or Indian Health Service. They have to have governing board members that reasonably represent those served, including, of course, those with lived experience. Staffing, required staff includes peers, psychiatrists as medical directors, medically trained behavioral healthcare providers, and individuals with expertise in trauma, serious education, emotional disorders, SMI, and SUD. Specific areas of expertise, so it is a comprehensive treatment and expertise array. And they're required to have regular training in cultural competence, trauma-informed care, and integration. I'll go into more detail on the integration part. One of the big wins early on has been expanding, by the way, access to and integration with substance use disorder in agencies that had little or no substance use disorder treatment. We're only focusing on mental illness. And then access to care, big increases in access to care. CCBHCs are required to have timely access regardless of ability to pay, to have 24/7 crisis response. They have, many of them have implemented same-day access where you get seen the same day you came in. Scope of services can include services they provide directly or under contract in an arrangement called a designated collaborating organization, so they can contract for some of the services. The care coordination requires partnerships and coordination agreements with FQHCs, rural health centers, inpatient psychiatry and detox, general medical hospitals, ER departments, residential programs, schools, police departments, and as I said, quality reporting, over 20 measures. Here are the 9 defined services: screening and assessment, patient-centered planning, outpatient mental health and substance use disorder treatment, crisis services. You know, we're all getting ready for the 988 rollout in this coming July. CCBHCs are required to have mobile crisis stabilization, 24-hour response, crisis lines. Peer support is required, psychiatric rehab is required, targeted case management, primary health screening and monitoring. They don't have to deliver primary care, but they have to coordinate with it, they have to screen for it, and if they have identified a need, it needs to go on the treatment plan so it gets addressed just like a housing need would get addressed, say. And they need to serve veterans and armed forces. I'm going to drill in a little on the care coordination integration requirements, since that's the topic of the day here. They're required to have care coordination and MOUs with FQHCs and rural health centers, inpatient, post-detox and step-down services, residential programs, schools, child welfare, Indian Health Service, VA facilities, and general medical acute care and hospital outpatient clinics, pretty much the whole array of their local community health system. Integration requirements includes coordinating care across all health services, including access to high quality physical health care. They need to go over the medications that they're getting from any other provider and share that information with other prescribers. They're required to implement population health management and have interoperability so they can electronically exchange information with other providers. They're required to contact people within 24 hours of ER or hospital discharge, or do the level best they can to contact the person that soon. And that doesn't matter if it's a medical discharge, a substance use disorder, or a mental illness, it's all cause. They're required to assess the need for medical care and to either do a physical exam or see that the person gets a physical exam or has had one recently. They're required to do primary care screening and to monitor key health indicators and to have their staff trained on integration. They really have an emphasis on targeting population health. And this is really made possible, especially in the demonstration states, by the prospective payment system, where you add up all your costs, you divide that by your visits that you decide are eligible to trigger a payment. So your total costs average out over your total visits and your costs are covered, and you can pay for things because it's included in that rate methodology, like a dedicated pop health analyst, clinicians. You can pay for your data analytics systems to get the reports so you can do individual care management and population health planning. You can develop care pathways. It allows you to strengthen integration with primary care because it pays for those non-face-to-face encounters to communicate with primary care and general medical care. It can pay for interventions like the ones that Gail described that may not have general billing and fee for service, but you could, those are costs that can be built into your other encounters, so your cost is covered. You can partner with hospitals to streamline. Many CCBHCs have hospital and ER liaisons assigned to those hospitals. You can assess for non-health needs. It really is a way to fill in all those gaps. I know those of you that tried to do integration have been frustrated by the funding gaps of things that need to be done to integrate care, where you can't find a fee-for-service code and grants don't last forever. 6 of the quality measures really focus on integration issues, mostly transitions of care, follow-up after hospitalization, follow-up after emergency room visit, all-cause plan readmission, adherence to antipsychotic medications. And this PPS methodology also makes it easier to handle health disparities because you have more flexible funding to cover those special needs. We did a survey of the CCBHCs and asked them regarding their ability, did the transitioning to the CCBHC program model and funding help them with disparities with people of color and access to care and reducing disparities. 75% increased screening for unmet social needs like housing, income, insurance. 67 developed organizational policies and protocols to improve diversity, equity, and inclusion. 60% hired staff who were demographically similar to the populations they served. Half of them initiated or expanded their translation services. So it's a good way to make progress on health disparities and inequities. Some of the outcomes that have been reported: Oklahoma, CCBHCs reduced the portion of their clients seen in the ERs by about 18 to 47%, depending on which CCBHC asked, and those admitted to inpatient care by 20 to 69% over the first 4 years. Missouri had a 20% decrease in all-cause hospitalization and a 36% decrease in all-cause ER rates. And you see here that they're holding themselves just as accountable for the general medical ER and admissions, ER use and admissions, as they are for the substance use disorder and mental illness driven ones. In New York, 54% decrease in the number of CCBHC clients using inpatient care on behavioral health, resulting in a proportional decrease in associated monthly costs. And New Jersey saw a decline in all-cause acute readmission rates from year 1 to year 2. Again, benchmarking on that whole person approach. Because, you know, actually, when you look at a lot of those medical admissions have an underlying behavioral health cause. If somebody has a manic disorder and gets in an auto accident and is physically injured, that'll be reported in the claim as a physical injury and not attributed to mental illness. So it really is important, because it's the whole person getting sick and the whole person that's impaired, to look at all causes as opposed to always subcategorizing. Improved access to care has been one of the big improvements on certified community behavioral health centers. On average, they're serving 17% more people, 17%, significant for those communities. Sharply reduced waiting times. National average for CCBHC wait time is now 48 hours. 48 hours to get in to see a CCBHC is national average. 50% have same-day access, 84% see everybody within 1 week, 93% see new patients within 10 days. So overall, they're better able to serve their communities. They're doing better at addressing health disparities. A lot of them are really focusing on crisis supports and on integrating with the ERs, with the emergency medical systems, with the police, to divert people out of the general medical hospital ERs, to divert people from jail, and to have that behavioral health first response, or at least behavioral health along in on it response that meets the person's need as opposed to being strictly punitive. And again, what really makes this possible is the prospective payment system. These organizations report that where before they were running staff vacancy rates around 25–30%, they're now running down around 5%. And of course, that decrease in vacancy increases your capacity to serve people, and the decrease in staff turnover increases the quality of care. Who wants to get a new case manager, a new therapist every year because the person left and got a better paying job? So filling those staff and vacancies really improves quality and access. They've added new service lines. They've been able to have a staff mix that better reflects community need. They're able to build non-billable activities, which is huge for integration. Again, the care coordination, the non-face-to-face, the data analytics, and the programs like the ones Gail's report that it's hard to find a billing code for. They can go ahead and implement now. So to put it all together, there are 114 certification requirements. So it's a standardized model. You know what you're getting. And if it's standardized, then you can measure whether or not you're getting it and what the performance of the provider is. And you can't improve anything you can't measure. The prospective payment system really has the funding to pay for that level of activity, that level of performance. The enhanced operation allows for same-day access, retention, high impact, doing better integration, better collaboration and care coordination, having time to coordinate with primary care, to do medical risk assessments. And overall, that leads to improved outcomes, which is reducing hospitalization and ER visits on the all-cause measure, also reducing incarceration and improving people's physical health. So a couple considerations, readiness. If you want to do this in your own clinic, you need to do an assessment. Contact us at the CCBHC Success Center at the National Council. We can direct you to people that can help you do a gap analysis, look at what your staffing needs, what new service lines would you need, what were your infrastructure needs, what would your billing technology needs, help you get through that first cost report. You can get good technical assistance and consulting with MTM services on both those. So you know how, and actually we found that one of the big improvements is they are better at business, not just better at clinical delivery, they're better at their business back shop, because that also becomes more data driven and more data managed. And then what state-specific options or opportunities are specific to your environment? What do you particularly want to do or need to do first in your community? So some implementation considerations. It does require collaboration between Medicaid and your state behavioral health authority, crafting the certification payment standards. It's a collaborative rate setting. It's significant work that goes into organizational and system transformation. The CCBH expansion grants are really a great way. If you haven't got one, then apply for the next round and get your application in. Mental health block grant funding. There's a set aside now to support clinic readiness for CCBHC. And CCBHC also, you can use, if you're getting any dollars that aren't Medicaid matched, it might be a way to double or triple those dollars by putting them in your CCBHC PPS rate and getting matched for them that you can't get now. So it's a way to leverage and make your money go further. Coming up next, broad bipartisan support. There's legislative proposals in the budget to expand the program further and give more opportunities for more states to go the PPS route. And you can go ahead and implement without congressional action. You can do that through either state plan amendments or waivers or managed care authorities. There's a whole range of options to go forward depending on your individual situation. Well, those are my prepared comments. I think I'll hand it back over. Let me unshare.
Excellent. Thank you so much, Joe. That is a whole lot of information, and thank you. So I do have just one kind of follow-up question, especially at the tail end of your presentation, and I appreciate you highlighting some of those implementation next steps. What are the issues and barriers y'all are seeing so far as people try and get involved in this work? What can they expect in terms of lessons learned and some of the issues?
Well, some states are very enthusiastic and doing everything they can to support their behavioral health community and going this, and others are more skeptical. So your level of state support can vary. Also, clinics' readiness to do this varies. You can do that gap analysis and find that you have quite a bit of work to do. That's especially if you haven't been able to invest much in electronic medical record and some of your IT structure. It can be a stretch. And if you're a very small agency, it may require partnering. It does require a comprehensive array. At the end of the day, you have to be able to provide both mental treatment for mental illness, substance use disorder, all those crisis services. And you may decide that it would require partners and figuring out those partnerships. And let's face it, it takes a while to build that level of trust, even with people you've known a while.
Fantastic. Thank you so much. One other question that came up in our from the participants: what should be the training and role of the PCP be in the behavioral health integration?
Oh, the PCP. Well, it depends on whether they're going to be internal on-site in the behavioral health team or whether it's referral. You can do integration at different levels. Even just coordinating care by having a really good screening closed loop where I refer someone and I'm told in the end they got there and what the results was, that's still better than no integration. In the Missouri health homes, we hired primary care physicians to be consultants to the behavioral health team. And in that case, they needed to get educated on what the team service and staffing model was, but then they were in regular communication. Right now, the FQHC that I work in just got acquired by a CCBHC. So we're doing a whole agency merger, and we're doing a lot of joint training. In the end, if you're in a full merged area like that, it's a lot of joint training as opposed to the old separate training.
All good answers. And before we switch gears, and Joe, feel free to jump in with any clarification. These aren't questions in the Q&A as much as comments. So the comment is communication between a primary care doctor and a mental health professional is really free. I've never had a problem with both professionals getting paid. A peer support system helps people work towards positive goals. I don't know if you want to say anything or expand on that.
I think the communication has gotten steadily better over the last 10, 15 years between general medical professionals and behavioral health. We are more open and responsive on the behavioral health side, and we've gotten away from thinking we can't talk at all because the information is more special in some way. That's about to increase markedly. The new ONC interoperability rules are going to have expanded what we're required to do. Under HIPAA, we were always allowed to exchange information if we wanted to, even absent patient consent, with the exception of 42 CFR and stricter local laws. And the new ONC information blocking rules that went on April 5th require us to exchange information unless we've recorded that the patient said don't share information. So I think it's gotten better, and I think it's going to get better. Now, the best communication I ever had, and COVID kind of knocked that out because now I see my patients virtually, is I was behavioral health in an FQHC. I still am. But when I was on site, I couldn't go to the bathroom without going past the whole row of primary care offices, and they couldn't get to the break room without going past me. And those informal communications were gold. I would see somebody and I'd be reminded, oh, I'm going to see their patient that they already see, and I got this question. So there was an earlier question of what model's the best. I've worked in them all, and I really like it when we're all in the same place. And by that, I don't mean in the same organization. By that, I mean I can't get around the building with, in and out of my office without running into my primary care colleagues. That it's fun, it's better quality care.
Excellent. And if I can pick your brain just about one other kind of pressing, I love the fact that you talked about screening, and especially the social needs screening. And since you've got that strong background in psychiatry, I am very curious about, and this will go over to Jerome's conversation with us as well, but what are the mental health screens that are being used? I keep on looking for, specific tools being used that really integrates that behavioral health aspect into these integrations. Tools that you've seen used, things that you're excited about?
The most prevalent one we see everywhere is the PHQ-9. The FQHCs have almost, it's virtually a requirement with them, and it's very acceptable in primary care. And they kind of just, they do it like blood pressure now. They're actually better at routine screening with PHQ-9 than many behavioral health organizations are. And it doesn't screen for everything, but it's a pretty darn good start.
It is. Excellent. All right, so we're going to keep this moving along. Don't go too far, Joe. We're going to come back to more questions. I know there's others that we need to get back to as well, but we're going to shift gears. We're going to go to Jerome. If Jerome, you want to get ready to come on video. As VJ had said earlier, we can't thank Jerome enough for quickly pivoting and helping us with this presentation. And it's exciting. This is a perfect match to what we've been hearing about with the CCBHCs, going back to the FQHCs. And Jerome Corley is a substance use disorder program coordinator. He coordinates and provides pertinent training and technical assistance to rural communities around opioid response programs in the Opiate Response Program Consortium. He serves as a resource on substance use disorders, behavioral health and infectious disease programming and services. Jerome is a graduate of Claflin University with a bachelor's degree in English and a master's degree in clinical mental health from South University. And we are very excited to have you on board.
Good afternoon, everybody. And I'm going to be talking about behavioral health programming in federally qualified health centers. And that's considered FQHCs. Jessica. So just to give you an overview of what FQHCs are, it's originated in South Africa. It was originally funded through the Office of Economic Opportunities. One cool fact about our FQHCs is that 51 of our boards of directors consist of patients of the FQHC, so it's a community base. We focus on medically underserved areas and populations, and also affordable health care. So for those who do not have insurance or those who can't afford doctor visits, there is a sliding fee scale that we go off by the national poverty level. We do have audits every 2 years, and then we do address all life cycles. Next slide. So one cool thing in this picture, so we do not focus on equality, we focus on equity. So with equality, everyone gets the same thing, but with equity, everyone gets what they need. So as you can see, with equity, the little boy can't see over the fence, but everyone has the same box. But with equity, everyone can see over the fence, and then the little boy have enough boxes. So that's what we do. We make sure that everyone has appropriate health care that is suited for them. So Jessica. So our mission at the Primary Healthcare Association is that everyone has access to quality health care for all of South Carolina. Next. Just a little background of what we are doing in South Carolina. So we have 23 community sites. 4 of them are homeless programs. We have 5 migrant health services, school-based health services, and 1 public housing. We have a migrant voucher. We have 201 service sites. So out of the 23 centers that we have across the state of South Carolina, some of those sites have satellite sites where we go into rural areas where it's more accessible to our patients. We serve about 387,713 patients as of 2017, and we have approximately 432 providers. Jessica. So just to give you a map of South Carolina and our sites. So there are, as you can see, some of these sites have different symbols, and you can see them all across the map. And then those are our targeted areas. Columbia, which is our central, Greenville is our upstate, and Charleston area is our lower state. Next. So behavioral health in the FQHC world, we're focusing on bringing awareness, reducing stigma, normalizing mental wellness, and then providing quality care. Next. So where are we now? Next. Just to give you a little synopsis of what we're doing. So as you can see, our annual visits by selected mental health and substance use, our numbers are increasing. So we are getting more visits from our patients coming in to see those mental health providers, and also addressing those substance use disorders and conditions. We're looking at alcohol-related depression. We're looking at other substance use, anxiety. Next slide. And then we're also looking at our annual patients. So as you can see, that's also looking for an increase. So we're getting more visits, more intakes from our providers. Our patients are fully participating in our FQHCs. Next slide. We're also excited about the patients who are receiving our MAT waiver training. So with our MAT, our numbers are increasing each year. So back in 2019, as you can see, some centers went from 0 to 16, some went from 90 to 1,088. So we're trying to increase that number each year. Next slide. And then we're also increasing our providers. So each year we do run a training for MAT waiver, medical assistant treatment program, to increase our providers to make sure that our patients are receiving quality care. So as you can see, we went from 7 in 2016, and 19 we were at 76. Next. So our FTEs are full-time employees. As you can see, it's calculated. So each year we are increasing. And just for clearer understanding, these numbers are calculated by the 40-hour work week that our providers are working. So we are increasing our providers' work and our providers. Next slide. So one of the awesome things that we as the FQHC and South Carolina Primary Healthcare Association was awarded the RCORE implementation grant, which is the Rural Communities Opioid Response Program implementation grant. And that is to aim to strengthen and expand substance use disorder services, including opioid disorders, prevention, treatment, and recovery services. And these next few slides are going to entail what all the grant has developed the programs under it. So next slide. So here we have our mental health first aid. And if you don't know what mental health first aid is to assessing mental health I want to say mental health crisis. So just as CPR is important, so is mental health. So CPR is not to prevent a heart attack, it's just to assist those who are having one. And mental health first aid is not to diagnose, but to assist those and recognize the symptoms of those who are having a mental health and substance use related crisis. So within addressing that, we have increased our mental health trainers across the state of South Carolina by 28 and adding 3 bilingual mental health first aid trainers. So we are excited about that. And we also at South Carolina Primary Healthcare Association have instructors who can train those who want to be certified in mental health first aid, as well as we are doing a pilot to where all of our FQHCs will be trained along with their board of directors, front desk staff, providers, everyone. So if a patient comes in, they can recognize the signs and symptoms of a mental health first aid crisis or substance use crisis. That way they can get them to the appropriate help that is needed. Next slide. So during, well, before COVID started, we were planning a team wellness program, and this is to reduce burnout amongst its behavioral health providers, along with primary care providers. But when COVID started, it was very essential. So what this does is it has it's an 8-week session, and they learn about the processes of burnout, what it comes with, what it all entails. And then within that, they also create what is called, they look at the 8 dimensions of wellness. They create their wellness plan, not only for themselves, but they also create a wellness plan for their learning, for their center, as well as those who work with them, so their cohort. And before each session starts, they start with a mindfulness based stress reduction activity. There's some quizzes, some handouts, and some other things that entails with that to provide them tools and tricks of reducing burnout and stress. Next. So one of my favorite programs that was started was the DSS partnership. So within South Carolina, there has been an increase of DSS lawsuits for the lack of care or the timeliness of care within the system. So in order for DSS and FQHCs to partnership, we have created a partnership as to where those children who are going into foster care or preventive care will be taken to FQHCs. With FQHCs will look at their behavioral health. So they'll have a behavioral health visit. They'll set up a behavioral health treatment plan for them. They'll also be able to see their primary care physician or get connected with a primary care physician, which is always located in the same building as behavioral health. And then some of our FQHCs has some specialists that's in there that those kids, not along with the kids, but also the parents, are able to access these different programs, such as our OBGYN services, our dental services, our optometry services, to reduce substance use and opioids. We also have some chiropractors in our FQHCs as well. So we're looking, we have done a pilot with one of our health centers in the north, within our upstate, which is Regenerative Healthcare. And now in 2022, we're looking to expand that with across the state of South Carolina, along with the hospital as well. So that's one of our greatest accomplishment under this program as well. Next. So As I mentioned earlier, we're always looking to expand our MAT waiver providers. So we hosted 2 MAT waiver providers in partnership with our South Carolina Office of Rural Health in 2020 and 2021, and we've added 27 new MAT waiver providers. And also we have another one coming up in November 16th, it should be 2020, yeah, 2021. So we're looking forward to adding more our MAT waivers providers as well. So that's an exciting thing, that one of the trainings that we have coming up. Next. So also with in FQHCs, we have our Ryan White networks. And with our Ryan White networks, we're addressing HIV. And with that, this grant has expanded. So the Ryan White Network only had 1 year of its quality plan. So CQI is clinical quality improvement. So we were able to expand that from 1 year to 3 years. The original plan was only looking at viral loads, patient visits. So we were able to expand that. So now we're not only looking at the viral load, we're also looking at equity measures such as racial inclusion. We're looking at behavioral measures, so substance abuse, depression, remission, all those other things that entail with that. So we are increasing our behavioral health services, HUD screenings, integration with our Ryan White services, and then we're looking to create registries as to where the health centers or our FQHCs are able to access those patients who are out of compliance or who are in need of testing, medical treatment, as well as care coordination. Next. One of the opioids or our HUD that we're looking at is increasing our naloxone with patients. So we're looking for screening for depression. We're screening for HIV, but also we're looking for a naloxone prescription. So increasing those prescriptions of patients with an OUD diagnosis, which is opioid use, along with those patients who have chronic opioid therapy. We're looking at decreasing patients with both opioid and diazepam to make sure that we are in compliance. So we're continuing pharmacotherapy, engagement of the OAD treatment for those who are 13 years and older. And then we're looking for treatments of those of 13 years and older patients with new episodes of alcohol and drug dependency. Next. So this is just a little of a dashboard that we're looking at. So we're not only looking at patients, but we're also looking at it as a deaggregated data. So we're looking at race. We can look at it as a payer type. So this is the dashboard that we build out. This is a pilot that we're doing with our health centers to make sure that our patients who have substance use disorder or opioid use disorder is receiving naloxone or prescribing naloxone in our pharmacy. And one cool thing about our FQHCs, we also have pharmacies in our building. So when a patient comes in, they can see their primary care doctor, they can go to their behavioral health doctor, they can see the OBGYN, a dentist, optometry, receive their medicines, and then go to the pharmacy, which is all located in the same building, and receive the medicines that they need for their doctor visits. Next. So we're looking at primary set of needs to adopt in the CQI measures. So looking at the trailing year and how we are increasing. So that goes along with the previous slide. And the needs to bring clinical quality measure mindsets that occurs with diabetes management and prevention quality work to substance use disorder and behavioral health programs. Next. That was the same. So next. Okay, so here are some of our next steps. So in at the South Carolina primary, so we're doing parity studies. So making not all South Carolina peers cover SUD and behavioral health services. And we want to improve that to make sure that all of our providers are being paid. And we're also doing a study along with Medicaid, because Medicaid in South Carolina does not support behavioral health providers being integrated into our care, onto the chronic disease treatment team through payment and services in alignment with our billing and coding. So evidence-based interventions around patient behavior changes is what will move the needle to chronic disease outcome in South Carolina. Our Primary Care Association is working to demonstrate the values of these services. Next. So just to look at a few things that we were doing during the pandemic, we were focusing on testing, so making sure that our patients, along with those in our provider care, are getting tested for COVID. We're providing extensive technical assistance on specifics around COVID. So we were hosting webinars and trainings for those with COVID. We were providing PPEs to all of our FQHCs, and we are still doing that today. So making sure that they have signs, making sure that they have masks, making sure that they have the appropriate gowns and everything for COVID testing to make sure that our providers are safe along with our patients. So we did not miss a beat. And every single scheduled network meeting that we have was flipped to virtual. So we did virtual meetings. We also expanded upon our telehealth medicine. So seeing those patients via telemedicine through the phone, through computer system, making sure that they still kept their mental health and behavioral health appointments, along with being able to do some intakes and stuff with our telemedicine program. Next. So we did our vaccine focus. So we successfully advocated for our vaccine statewide, allowing the bulk of vaccine administrator uploaded. We co-sponsored with South Carolina COVID and Grand Rounds weekly webinar. We were facilitated some FQHC focus days during South Carolina DHEC COVID Vaccine Action Week, and also some of our fairly qualified health centers were able to partner with different communities or churches. They are still doing some vaccine workshops there, making sure that people in the community are being vaccinated. So they go to churches some days, they go wherever DHEC is asked of them. So we have increased the needle. So we had 200 vaccines shipped to over 139 FQHC sites. So that was an awesome accomplishment for us during this COVID season as well. Next slide. And that is what I have.
Excellent. Thank you so much, Jerome. Excellent. So lots of things here. So one is, I hope everybody's realized in every one of these presentations, data rich. So I'm really happy to see those data-driven reforms. Jerome, before we bring back the entire panel, just a couple of questions interested in hearing more about. You highlighted that you are truly community-based and that membership participation in these activities, these boards. How do you all go about recruiting, especially members, and making sure that they're included?
Well, with our board of directors, they are patients that are selected. So it's just like applying for a job. So what they do, they'll put in, if a center is looking for a board of director or someone to be on their board, they'll interview, they'll see how active they are in the community. One of the requirements is that they are a member of their health center, because the only way you can best serve our patients is to know how it is to be a patient. So that's what they do.
I love that inclusion. Thank you. One other question, because I think this is pressing. As I've talked to folks with FQHCs and operating with FQHCs, I think one of the things that I consistently hear as a struggle is that integration of substance abuse treatment. And one of the things that I'm hearing highlighted in your presentation is that integration with substance abuse treatment. Any reasons of why you think you all might be ahead? What are you all doing that's special in really getting substance abuse involved?
Well, we looked at those in our community who are suffering from substance abuse. And one of our main things is we do stream for substance abuse. And then I did not talk about it in our slide, but we at South Carolina, I believe some other associations as well, purchased a healthcare population tool called Zara. And then that healthcare population tool alerts us to those patients who are, give us a PIT score. So those patients who are at risk of substance abuse, those patients who need a screening for substance abuse. So it gives us all of the intel of what we need to know, so we can stay ahead of the crisis or to management better.
Fantastic. And I'll just highlight one other thing. I love the fact that you brought up the vaccines and getting out that PPE as part of what you all did. As the rest of the panel comes back, I would just highlight, VJ put up on the screen that that shot of the float during one of the conferences, previous conferences. That's the Crew to Boo. And for those of y'all that don't know, just when you're feeling like, are we coming out of this pandemic or not, Crew to Boo actually did roll the other night, and we had our first big parade in New Orleans since the pandemic had started. So that was a good refresher. So if Joe and Gail want to come back on camera, we'll start jumping into some more Q&A. And exciting stuff. And I'll just go down there a couple of things. Please continue to load up your questions. I'll try my best to get through and navigate this for the panel. And for the panel themselves, Gail, Joe, Jerome, feel free to ask questions of each other. You all are living this every single day, more so than I am. And so take the deep dive as well into.
Well, I did have one follow-up to Gail's earlier comment about health homes for chronic conditions, Section 2703 health homes, and not having many primary care ones. You can go to the health home for chronic condition website that CMS has, and they are about 2/3 behavioral health, but there's about 1/3 primary care. So your options are, you can set up one's just for primary care and one's for behavioral health. But actually, you can build your health home with requirements to involve primary care. One of the regrets I have in Missouri that we didn't realize till after we had our state plan approved is we actually could have put in some money for the CMHC to give a PMPM payment to a partnering primary care, like an FQHC. And we didn't build that in because we didn't think of it at the time. But the actual model would allow you to do that. You could put in and say, well, I'm going to give all my partnering FQHCs, $2 per member per month if they're seeing the patient too, just to do business with me. That's a program choice you get to make as a state.
Excellent. So since Joe pointed you out, Gail, I'm going to start. I'm going to go back to a question we had early that we didn't get to, and I want to call your attention to this one, Gail. The question reads, as you are aware, there are many levels of integrated healthcare. In your research, what is the most effective level of integration? Full integration, where primary care provider and behavioral health provider work in the same clinic, or some other version?
Yeah, so thanks for this, and thanks for everyone's great presentations, my colleagues. Yeah, so I don't think that there's great evidence for this, right? Like, I mean, we haven't tested it kind of head to head in a really rigorous way. So I think I would really just kind of go with what Dr. Parks said before, which was that, kind of on a practical level, when you walk out of your office and you're walking to get some coffee, if that's allowed during COVID, or you're walking around and you see someone and you do kind of a curbside or a check-in, or you see a different staff person who's supporting another office, that it's really the kind of the co-location that I think is really great. Although again, we don't really know with evidence, I'll say as a researcher. The other thing is, shared medical record, which is, not totally prevalent across the country, I think is really important, and potentially could substitute for a physical location to a certain extent, and with prompts and kind of messaging, the physician provider to provider messaging, whatever. But again, we don't really know. So, but I would say higher is better.
Well, and I'll give you a preview. National Council, we're going to be releasing a major paper on integration, probably in about 2-3 months from now. And in it, we address this directly. We kind of come up with 3 major conceptual models of different ways to approach integration, one of which would be comprehensive care, where you have primary care and behavioral health in the same place. Another would be more the health home arrangement, where you're doing actually population management, care coordination, following up, and a lot of screening. Another would just be really tight referral, follow up on referral, make sure it happens, screen for everything and refer and make sure it happens. And actually, I think you're better off with a small practice that really has referral and screening tightened, is doing it well, than in a huge system that's doing comprehensive care very poorly. Because each of those have a range of how well you execute them, how thoroughly, how systematically, how engaged you are. And some practices, if you're in a little clinic with 12 people, you're not going to do comprehensive. You don't have the scope and power. You do what you can as well as you can with what you got. And it's better to execute 3 simple integration things well than 40 complicated integration things poorly and sloppily and inefficiently.
I think that's really well said. That's exceptionally well said. So I agree with Dr. Parks.
I'm curious, especially Jerome and Joe, on that whole referral and integration of services. Does it matter which door somebody walks in, if they are calling you for behavioral health services versus walking in for a healthcare visit, primary healthcare visit? Does it make any difference? And
I'll tell you one thing where it matters, where even a solo practitioner could get better on the behavioral healthcare side. Me as a behavioral health guy, if I send somebody out to primary care or general medical care, I send them to an internist, I always get a letter back addressing my question and thanking me for the referral. I don't have to send out for a record. They send me a letter saying, "Dear Dr. Parks, thank you for sending Sam. Here's what's wrong with his stomach." We don't do that. People send us people in primary care will say, we're like the great black hole of information. And we don't automatically push information to our partners. And sometimes when they ask for it, we send them a form and say, "No, I don't like your form, sign my form." That is the height of cultural rudeness in general medical care. It is culturally inappropriate. And
great points.
Sorry, I got me on a random soapbox issue.
No, that's fantastic. Jerome, you want to add anything to that? Does it matter which door they walk in?
Well, no. So I used to work in the FQHC before I went to the Primary Healthcare Association. And one of the things that was focused on was making the health center a medical home. So you get one-stop shop. So before patients would leave, either if they went to their behavioral health provider or their medical provider, if there needs to be referred throughout the facility, then what they would do is make that appointment there, hand it off that way, and then that way they already have what they need, whether it's that same day or they have to come back the next day. So it doesn't matter who's referring, just know that there's a handoff and then they have notes and everything for what the patient needs.
Excellent. Thank you. So I'm just going through some of the lists that I've got in front of me anyway, question-wise. One of the participants said, I agree with Dr. Parks. Everyone in the same place is really helpful, although evidence to support this would be great. And I would just add one kind of caveat to that. Are y'all finding any difference now that, so like Dr. Parks had said earlier, he's on telehealth all the time. Is there any difference in how these operations are having and the advent and the strong reliance on telehealth for a lot of services?
Well, when it was telephone only and we let the patients do it from the home, nobody ever missed an appointment, though I missed seeing them and I couldn't do quite as well seeing them. Now that I'm back to a model where we make the patient go to the clinic and I'm back to getting patients not showing up because they can't handle the transportation, the burden, the cost, the inconvenience. The distance creates problems. You have to work harder. It's more work. It's more work to get the same level of connection and integration virtually.
Mm-hmm.
You can do it. Takes more effort and time.
Yes. Telehealth has been a great access. So we found that more patients were more compliant with their doctor visits and things of that nature. So some of our health centers now has purchased mobile units for those who are unable to come to the clinic. So the mobile units are more accessible in the area where they can come visit the doctor that way.
And I see the question from Jan, how do FQHCs work with providers to see more seriously mental ill patients to ensure they get more intensive placement correctly? Jerome, you want to take that first, then I'll talk about how we've handled it at my FQHC.
So at our FQHCs, what we do, if there is a patient that need more serious, then we also partner with the Department of Mental Health, which is located around South Carolina. So they have different local offices. And then we also partner with the hospital to make sure that they're receiving those patients. So if there is a patient, for instance, that comes in that's having a psychotic episode that is out of the bounds of our provider, then we'll call in Department of Mental Health. And then what's good about it is that it's right around the corner or right next door. So then they're transported there. So that way they're getting the access and the medications and the things that they needed from those who can't provide it in our FQHCs.
Excellent. Thanks, Joe. You said you had something to add to that?
Yeah. So, we have the FQHC I'm at in Columbia, Missouri. There's 2 or 3 CMHCs in the area. And of my patient load at any given time, maybe 25–30% will also be with the CMHC, and they're seeing me as psychiatry. So if somebody just comes in the door and they're not with anybody, we'll treat them as much as we can at the FQHC. We do time-limited therapy, like brief therapy, 10 to 12 visits or so, and have a little case management to sprinkle on them. If they need longer therapy, they get referred over. If they need psych rehab or case management, in terms of the level of integration, it varied by the case manager I have to work with. Some show up and exchange more information, and some do less. Sometimes the patient decides to switch over to the psychiatrist at the CMHC, and sometimes they insist on staying with the FQHC because that's where primary care is. So it ends up being split most of the time. you know, and it waxes and wanes depending on the person's desire.
Thank you. There's a real specific question. I'm not, do any of the FQHCs use the collaborative care model, formerly the impact model, that you all are aware of or can speak of? I'll take that as a no.
Stephen,
Another question. Yep.
I can sort of say that I know that there are billing codes for the collaborative care model in FQHCs, and I know that HRSA and I think Medicaid and Medicare support the collaborative care model. My sense is I know that there are FQHCs in sort of some of the Western states, I think Washington and Oregon, that were doing the collaborative care model. You know, it's a proven model, and I know that if one goes to the HRSA sites and they've developed, you know, the CPT codes, and they're very billable, and there's very specific ways that collaborative care can be billed within an FQHC.
Excellent. And Vijay, since you're here, you want to ask your question about the different missions and in terms of the services offered?
Yeah, you know, I guess I know we've talked about how there's collaboration and sort of cross referencing of people being served. But, you know, it does seem to me that it's kind of, you know, we have the old community mental health centers that are becoming CCBHCs. My understanding is that there's a lot of new funding coming down for CCBHCs. Then you have the federal qualified health centers who are going to get a huge injection of new funding. And so to me, what I'm not very clear about is how all this stuff that's going into a particular locality is getting coordinated, and whether the siloed funding is creating sort of like, instead of sort of pushing the envelope, might be creating tensions and competition. And so my real question was, do these, is there clarity about the different missions for behavioral health in terms of services offered or target populations for CCBHCs and FQHCs? And I think some of the second part of my question was answered by Jerome and Joe, that, you know, I was asking, well, what is happening to coordinate not just services for an individual, but is there something that's going on at a higher state or sort of even federal level to do some coordination across FQHCs and CCBHCs?
I know that SAMHSA and HRSA frequently have conversations. I'm not aware of how they structure the frequency of those conversations. I agree that the amount of coordination could be better than it is. But, you know, I can say that about almost anybody I'm coordinating with.
But that's, you know, and this is in the spirit of dialogue and discussion, but, you know, I mean, that's a very diplomatic answer, Joe, but I was just trying to understand, well, if, you know, the panelists had their druthers, what, I had the,
you know, GJ, I'm a command and control guy, so I'd have us all on the same cost report. I'd have us all on the same core measures. I'd have us all, you know, linking our electronic medical records up to the same mega database so I could do modeling, but I'm a command and control guy.
Yeah, no, I understand. But, you know, I actually was working in a county in California where it seemed like there was very little communication and coordination across an FQHC and a community behavioral health center. And in some ways, there was almost, there were almost like two siloed worlds. And so that's part of the rationale for my question.
Well, you know, I've seen some that have done so well together, they ended up merging. And I've seen a couple that can't be civil with each other in the room. And in the end of the day, leadership matters. And CEO leadership matters, and board leadership matters, because both, you have to have a CEO that, for it not to work well, you got to have two CEOs that don't want to work well, and you have two boards that put up with it.
Jerome, anything you might want to add to that?
I agree totally with Joe. So it depends on the leadership.
All these organizations have community boards that are supposed to represent the community wishes. And the communities ought to wish harder for something else if they don't like what they're getting.
Absolutely.
Excellent. We have a few more questions up in the chat. While I'm gearing up those, because they look like they're going to go highly to Jerome and Joe on several of these. Gail, I do want to come back to a question for you. I think one of the things that you framed up really well in your presentation was a lot of the needs, the interest. This isn't, how we couch these sometimes as behavioral health or mental health or physical health. I think you reframed a lot of this. People want a better quality of life, no matter who they are. And do you have any recommendations about measures for quality of life that you would you'd put out there?
Yeah, that's a good question. It's a little bit of a hard one because I mean there are like some like quality of life like SF12. There's some. I don't know. I don't want to say I don't know how great they are. I think that like shorter ones are better if we're talking about integrating them into regular practice. But I think that ones that are more about I forget what they're called. It's more like kind of functioning or like client satisfaction. Some of the like basic older measures are probably good. That like they're like maybe from the 80s or something. I don't know. Joe might have more.
You mentioned the SF12. It's a good global function satisfaction.
Yeah.
Like country or not. The HOUSEKEEPING is very nice. The World Health Organization HOUSEKEEPING 5.0.
Yeah.
It comes in 20 languages and 4 different formats.
Yeah.
And it's free.
Excellent.
Yeah, that's a good one too. Yeah.
Well, thank you for that. I love the fact that we're looking at people's broader life and not just
totally.
I was always kind of sorry that when they let us stop doing the GAF and the DSM that they didn't start making us do the HOUSEKEEPING.
Yeah.
Well, excellent. All right. So one of the questions that is in the Q&A, how do we start breaking down the traditional silos between primary care and behavioral health? Are there structural or process approaches that you've seen work?
Lunch and donuts. Seriously.
That is true. Lunch and learns. We do a lot of lunch and learns. And so process mapping, all these different type of things, benefits of what could happen when we work together. So our lunch and learns are very, very good.
So we had a CMHC FQHC integration initiative in Missouri, and you had to apply as a pair. I think they need to be given. One thing SAMHSA and HRSA could do is put out grants that you had to apply for as a pair between an FQHC and a CMHC or a CCBHC. We offered $200,000 a year. The CMHC got $100,000, and the FQHC got $100,000. The CMHC could only use its $100,000 to buy things from the FQHC that had to be delivered on site at the CMHC and recorded on their chart. And the FQHC could only use their $100,000 to buy things from the CMHC, and it had to be delivered on site at the FQHC and recorded on their chart. We basically paid them enough to keep them in the room with each other, and we got 5 mergers out of it. We did stall out after 1 year, a year and 18 months or so, and the intervention was to stay in the grant. They had to do a 1-day retreat with each other. And in the morning, the CMHC explained their service and business and staffing model to the FQHC. What services they did, what volume, where you make money, where you lose money, where the revenue comes from. And in the afternoon, the FQHC did the same thing. A lot of the friction and difficulty getting along is they assumed that the other party had the same constraints and incentives they did, which was not true. And after they sat down and took a full day to learn each other's business model, they became much better partners. And they got kind of slick at where they could leverage against each other. So it's really getting them to spend enough time together and giving them a piece of work to do together with enough money in it that it keeps them at the table and in the work. For my government
Relationships.
view. Yeah.
Relationships and funding. I like it. Jerome, anything you want to add to that in terms of how to keep them in the room and working together?
Just food.
I have a story
Donuts, yeah.
from about 20 years ago where there was coordination that was needed around this whole integration stuff between mental health agency and Medicaid. And there was one state where they had done an incredible job of this coordination that sort of stupefied a lot of people from the other states. And so we were asking the mental health director, how did he actually manage to do this? And he said, I wound up marrying the director of Medicaid in the state. So just telling you, there are other models as well. So,
well, cross hiring is very powerful. You know, if you agree strategically to cross hire each other's staff, and one of the best paying things we did at mental health was when Medicaid would have a vacancy, we would encourage some of our best staff to leave us and go work for Medicaid. And that works with CMHCs and FQHCs. Sometimes the best thing you can do is give up one of your great performers if it's to a key ally that you want to be better with.
and
Great advice.
And I'm just going to toot the horn for one of our executive committee members, because she used to be the director of local behavioral health authority in Louisiana, in Baton Rouge, Jan Kosofsky, who's asked a couple of the questions. But now she's done exactly that. And now she's director of behavioral health for an FQHC. And so she's actually been asking some of the questions that are on here. But she has that broad sort of experience. And I don't know, Jan, if you've got other questions that you want to ask.
Jan's got more in the in our Q&A. In fact, the next question is from Jan. How do the FQHCs typically work with providers who see more serious mental illness to ensure patients with higher level of need can get more intensive services correctly? So that could be for any of you all. Those higher level need, more serious mental illness, is it referred to these integrative care locations? What's the best way to address and make sure they get their correct level of service?
Have a good relationship with your mental health agency. The FQHC knows when it's in over its head. It's just not always sure it can get timely, prompt help. I mean, if the last 10 referrals they sent over had to wait a month, well, why call? I'll have them they'll be in the ER before that. So if you have a good relationship, then it goes real quick and easy. You pick up the phone and say, hey, I need some help here. And they say, oh yeah, sure. Who is it? We got something tomorrow.
Timely access. Excellent.
And doing something for a partner you can't get away from. If you think about it, a CMHC and a FQHC in the same community are like people that are married that can't get divorced. They can either have a good marriage or a bad marriage, but nobody's going anywhere. They don't know, they think they can get away from each other. That's delusional.
All right.
Dr. Parks, I find your comments wise and enjoyable at the same time.
Thank you. Well, we have to make it fun. It's hard work. If we don't have fun, we won't keep doing it.
That's right. I like the comment you just made. I'm going to remember that one and you attribute it to you. I may use it in the future.
Don't even bother to attribute, just spread it around.
Yeah. Sorry to interrupt there. Okay.
No, you are good. Nobody's divorced here yet. So we're all still in this together on this panel anyway. So let's go to, so we've got a question up here, barriers to delivery of on-site primary care services and behavioral health programs due to regulatory licensing requirements and billing limitations, such as prohibiting same-day billing for behavioral health and medical care in FQHC are an issue in integration of services. How do you suggest we address these issues? So billing, access, getting paid on time? How are we doing? How do we address it?
Well,
So,
go ahead, Jerome. Yeah.
so for us in FQHC, what we do each year, we have an advocacy or a P&I policy conference where we go and address our politicians and those to let them know the services that we need to get billed for, the things that we can get paid for, and then also what we're doing now. So lucky us, our Medicaid has a new director. So our Medicaid office has a new director who was former boss of our maximum of revenue. So he asked us to write a policy to give some of those providers who we want added those things, what can Medicaid should do and shouldn't do. So we're in the process of now writing a new manual for behavioral health. So
Wow. Fantastic.
So the same day billing issue has been dwindling over the last several years. It was most common in states in the FQHC system where they had a single payment across all diagnoses. So for the FQHC prospective payment, you can have a single PPS, and they're all daily PPSs, or you can have a separate PPS for mental health, and you can have a separate for physical, and you can have a separate for dental. A lot of them have 3 PPSs. It was never an issue in the states that had separate PPSs. It was always an issue in the state, when it was an issue, and it wasn't in all of them, it was the states that used a single PPS. And it was mostly an uninformed Medicaid agency worried about paying twice for the same thing in the same day because they couldn't figure out if they let mental health bill it, then how would they could figure out if somebody else wasn't billing it. It has been dwindling. It's still a problem in some states. Some of the bigger problems we tend to see in the around licensure things, where for whatever reason, they've made different licensing regulations for the substance abuse clinic than the primary care clinic, than the mental health clinic. And some of it, I frankly think, was old turf warfare. People just intentionally, at the behest of the provider groups, set up separate standards so other people wouldn't poach to keep other people out of the business. I mean, for a while, New Jersey, you had to have a separate entrance for primary care and for mental health, and you couldn't keep people with substance use disorder in the same waiting room with people for mental illness. It was all licensure. It wasn't in the Department of Mental Health, it was licensure. These are things that you have to lobby locally about. And it goes best, the bigger group of providers you can get to complain all at once. The other place it goes is if you're going to change the regulations for some other general purpose anyway, it's easy to slip in, especially if it's something like the waiting room or the doorway or, you know, just inconsistencies. But boy, they can shut things right down. And it takes a lot of lobbying and a lot of noise.
I like that that local level. Maybe kick it up back to the larger federal level too. I know, Jerome, in your end of your presentation, you brought up parity, the parity laws. Are y'all seeing evidence? And I hear some of it in just the way y'all are describing some of this, but are you seeing evidence that we're getting closer since the inception of the parity laws?
we are still in the research phase, so I can't answer that fully. But hopefully by the end of 2022, I can have a better answer for you.
Okay. Looks like we're going to be calling you back. Next year's a good year. And we may be live in person in New Orleans, so that might be an added benefit.
For most of the big coverage, it's much better than it was on the quantitative limitations. You know, the deductibles are the same, the copays are the same, the visit limits are the same. You know, there's still a lot to be done on the non-quantitative limitations, the having more rigorous prior authorization for some behavioral health services than you would for comparable med surge. So huge progress on quantitative limitations, moderate progress on non-quantitative, but it's definitely better than it was pre-Wellstone-Domenici, way better.
Excellent. So we do have a question up in the Q&A. Have many FQHCs moved to offering medically assisted treatment? It is crucial.
Yes.
They've all pretty much been close to required to, haven't they, Jerome? I think they have to now.
Yes. So that
And so do
we try to
certified
have.
community behavioral health centers. They got to do it too. They must to be in the game.
Mhm.
Excellent. Well, that was a very simple answer. So Gail, I'm kind of curious on your part. Actually, not kind of. It was minimalized. I'm actually incredibly curious. What's the next steps in research on all this?
Yeah.
Yeah, so thank you so much for that. So I showed a little bit at the end about this implementation trial that we have from the National Heart, Lung, and Blood Institute. I mean, I think there are multiple different fronts, right? Like we still kind of can improve on, we can create more evidence-based interventions to help community mental health clients. So we always can do that we always need that. But I think that really the focus is on implementation and scale up. How do we, in this complicated world that we live in, how do we train and support both, at an individual level, a practice level, an organizational level, a reimbursement level, physical health interventions being delivered, whether it's in an integrated care setting or not. And the way to do that is with implementation science and to test it kind of in some different kinds of study designs that are maybe, there are things called SMART designs, which are these adaptive trials that can change over time, depending on how patients and clinicians respond. There's some things like step wedges. There's different designs and different methods and different implementation strategies that, like at the organizational level, that we use. We know training alone is not super effective. It works for when it works, and then people, don't have time and they forget about it. So that's really the space that I'm in now, which I really like. And it's hard. So I'm working in that space now, and I'm still working, I'm also still thinking about other, other programs that are much, directed to patients. I think another place where research is or should be is looking at peers and really looking to see, the country has a lot of interest right now in community health workers. Peers kind of predated them to a certain extent, right? But I think that we can do more with peers, and we should study and have a better body of evidence about what peers can do, how they can be best supported. So that is another area that I'm working in. And then I think finally, we're not quite there yet, but thinking beyond cardiovascular risk and really to other kind of medical conditions. I mean, obviously we have like the SBIRT model. We've already done work, and people have done work in hepatitis B and C, HIV. Those still are, still important. But thinking about cancer as a big comorbidity that really has, there are a couple people doing research on it, but it hasn't really been as addressed systematically. Where does that fit in? And then of course, COVID, which is, we already have some work showing that we know the populations we work with are at higher risk, but we don't really know what COVID's going to look like in a couple of years anyway. And that, but, really thinking about how to think about our population with that or other pandemics. So I don't know, there's a lot to do.
There's
I
a
need
lot.
funding.
I actually want to jump in on one of your points, peers. I was talking to one of our peer advocates for the state the other day, and she made a remarkable comment. I think she was right on the money, which is how do we, in our implementation and our very conscientious work to bring all of these things to scale, how do we help remind these agencies and organizations that peers are not just a cheaper workforce that can go out and do all the services, but how do we actually have their role recognized for what it really truly is, which is that lived experience, that listening, and that supportive care that they can offer. Any experience from anybody on that one in terms of really integrating peers well into the services?
I mean, it's really important. I don't know. I mean, the wage I can't speak to. I don't know, maybe Joe or Jerome would be able to do that. But I think anyway, we really have an untapped resource that should be making, the appropriate wage and get more respect, even more respect, because the lived experience is something you can't it's almost like you can't put a price on it, right? You can't, how can you even value, it's hard to put a value on that because really it's so high, right? Like any kind of barriers or stigma or like self-stigma, I forget what it's called, that people might be feeling, where a peer could really be that bridge and help them be able to open up to a primary care physician or open up about their smoking. And yeah, I just think it's invaluable. I don't know.
Excellent. And
Can I just
go
follow
ahead,
up
Joe.
on that? Because it just seems to me that, when you look at this whole issue of integrated care, when you look at other systems of medicine, Chinese, Tibetan, and so on, those are so interwoven in the sense that there isn't this sort of bimodal world which has to get coordinated as much as if you have hope and if you have sort of optimism. In many systems, that's supposed to result in better physical health and vice versa, right? And so I'm just curious how you, I guess there are two questions I have for Gail. One is, how do you start sort of like incorporating almost like the non-medical peer-like interventions as a sort of factor that contributes to the positive outcome in research, because sometimes it is that. And then the second question I have is really for Gail, that based on all the stuff that she's done, is there any work that has been done to follow that up in terms of sort of like a more economic cost benefit?
Oh, yeah.
Because that is a huge component to, it seems to me, in terms of the implication of your work.
Yeah. So I guess, go ahead. Sorry. Is it to me? I guess I can start with the second one first. I think we need more cost effectiveness analyses. I mean, I think that one issue is that the NIH has not well funded those kinds of analyses, and they've actually kind of said, we don't want them. There was some period of time where I don't know, Joe, if you remember, they were like, we don't want these in your grant, take it out of your AIM.
Yeah, they didn't want any science that went to whether things were being paid for right or not. That
right. So I think that we need, I guess, I don't want to say we need more data because that's like bad to say that, but like we need more data. I mean, we did one analysis of like the weight loss intervention I developed, and we showed that it was pretty similar to other ones, but I think there's still a cost intensity there. So I think we need more studies on that. I think that the first question you're saying, which I think is about what you're saying, is like, how do we look at peers and what they can really bring kind of overall, whether or not they're directly affecting like a heart disease risk factor? Is that kind of what you're saying? Like, how do we evaluate or assess like their benefit? Is that what you mean?
Well, I think I might not have phrased it very well, but there's this whole somehow these intangibles that I think in many cultures are seen, if you're sort of like socially connected, if you're
right.
And so on. Those things are probably as contributory in some areas to better health or better mental health. And those are not medical interventions necessarily per se, but in a sense they have consequences,
Right.
Yeah.
So I think that, so I think that's really important. So I think that we're not great at that in the US. Like, I mean, universally, like I think there's some organizations that are obviously better at it, but I agree that our culture is not built on that as a premise as much. I think that there is a field, I mean, our group is getting into this kind of social network analyses where you look at, the people that people are connected to, which includes peers, includes other people and their friend, who they live with, whatever, their family, other people that are their peers, but maybe they're not like peer specialists, whatever. And like kind of looking to see how those networks are then related to mental health, physical health, quality of life, things like that, and how they may be related to like their interventions that are being delivered, or like if you can actually have a social network like intervention where you're connecting people and then what happens, right? So that can be at the clinician level, but also kind of more at the patient level. So I think that there is research, like I think there is research around that. It's less for this population, but we are doing some work on that in our center. And there are some like methods that I don't really understand that we're doing, but that I think are interesting. So I think there's a lot more room for that. I think if we, you know, from a researcher's perspective, I think if we quote show that these, you know, that there is benefit like by doing these analyses, then, you know, maybe that's one way to argue for it. Although, you know, I think just from like a basic common sense, we would say like, we need more of this, right?
Thank you.
Great points. Joe, were you going to add something to that?
Oh, just a couple riff thoughts on it. You know, the stuff about the non-clinical stuff being valuable, that's what Richard Frank concluded in Better But Not Well, that people with serious mental illness are massively better, but it's mostly due to SSI disability checks and Medicaid and Medicare coverage, not to new antipsychotics and cool new evidence-based therapies, that those simpler things gave them much more benefit. I think on peers, you know, they on the peers, the whole movement has the problem of having, you know, kind of like won their point. Everybody's thrilled and wants more of them and wants them on the team. And the problem is when you're on a team, people want you to do all kinds of stuff you didn't want to do. I mean, when I'm in clinic, I'm spending about half my time doing the unique stuff that I really want to do. And the other half the time I'm doing other things that people insist that I do. And that's what it is to be on a team, you know, so that we have some dynamic tension and some conversations to have there to figure that out, to really figure that out with each other. The third one is, you know, on the social connection, we are morally conflicted in terms of really helping people with what they want, which is a romantic partner or a friendship. We do not have supported dating programs. We do not set up programs where we get all the single people that want to meet someone and have structured ways for them to have interactions and figure out how to make them better over time so they can actually have the level of intimacy they want, because it scares us silly that we get criticized for it. So we have some internal work to do there. I mean, my case management program is I got married, so I get a case manager. And I've noticed with all my patients, when they're partnered up, they do massively better than when they're not partnered up. The men even more than the women. There would be a tough piece of research, Gail. I'd love to hear your discussions with the IRB.
Ironically, I am now running the IRB at Johns Hopkins, so I may be able to have some leeway there.
It's good.
We call that.
But I love this social networking. Yeah, I love this whole thing about like finding a partner and supporting that. I'm all about that. I was gonna click on something on the Zoom that was like the cheer thing, but I don't, it's disabled, I think, so.
Yeah, could we do some combination of speed dating, hookup platform with couples counseling over time? We might actually get a treatment adherence to that kind of intervention.
I guess
social support, social networks never fail. They add to the puzzle. Fantastic. Jerome, anything you want to add on the peers or any of this discussion before we start pulling this to a close?
No, just that we at our FQHCs, we have peer navigators. So we hire peer navigators. And now at the association, we're working towards a grant to increase our peer navigation and finance them being able so they can receive money. And then also, like I mentioned before, with our Medicaid manual, we're trying to write in peer support specialists so they can get paid through Medicaid or whatever it's that when they're providing support. So
excellent, fantastic. And I Gail, I just want to make sure you see as well. Dale put in just a comment that wanted to make sure that you saw.
Yeah, I think I responded to it, I thought, but maybe it didn't show up.
Excellent, fantastic.
Yeah.
Appreciate it. Well, I can't thank you all enough. It has been a very informative and again, data rich, information rich discussion. So thank you very much for your time. And I'm going to turn this over to VJ. He's got the closing comments. But I can't thank you all enough. And this is the part where you get applause that you can't hear because we're virtual.
Well, I just want to echo what Stephen just said. Thank to all the speakers. You guys did a fantastic job, and thank you, Jerome, too, for joining the group at the last moment. I really learned a lot myself. One of the things that I have to do, a housekeeping thing, is just give people the code so that they can submit their CU evaluations, and the code that Melanie has for today's session is, I'm not sure where this comes from, but it's NASHPD, NASMHPD -11. I'm going to repeat that. NASMHPD -11 is the code that you need to send in with your CEU evaluation to get your CEU credit. Again, in closing, I want to thank everybody on the panel. I want to thank everybody who was able to participate and join. And so thank you again. Just a reminder that next Thursday we have our last session, and it'd be wonderful if all of you can join that as well. Thank you again, Jerome, Joe, Gail, and thank you again, Stephen, for being such a great moderator. Thanks.